immunodeficiencies. Again, this is going to be kind of an abbreviated version, but at least hopefully it'll give you guys a little bit of a concept of how to go about thinking through immunodeficiencies. So we'll go ahead and get started here. And this is not meant to be all-encompassing by any means. So hopefully by the end of this, you guys will know kind of how to think through things from a secondary immunodeficiency standpoint. Think about who to screen for immunodeficiency, know the 5 different types of primary immunodeficiency, and understand general treatment principles. So really and truly, the best thing for you guys to think about, or the easiest thing, I guess, for you guys to think about when it comes to immunodeficiency is first off recognizing somebody might have one. And then if you can get it into the different categories of immunodeficiency and know some of the specifics of the different immunodeficiencies that are out there, you should be able to then figure out, okay, well, this is the type of immunodeficiency that somebody would have. And so with that being the case, we'll start out actually with secondary immunodeficiencies. So secondary immunodeficiencies are actually things that are typically acquired, right? So something that's brought on by another process. Things to think about are co-infections, right? HIV, sepsis, overwhelming infections, malignancy can create a secondary immunodeficiency, obviously. If you have bone marrow failure and you're not producing the type of cells that you would need to fight off infections. Nephrotic syndrome, obviously through the loss of different complements as well as immunoglobulins in the urine, will create a secondary immunodeficiency. Diabetes, functional asplenia, or actual asplenia can create a secondary immunodeficiency, particularly in our younger patients and our patients with sickle cell. Drugs obviously always will be on the answers of something that can cause problems in children. So drug-related marrow failure can certainly cause it. A secondary immunodeficiency. And then malnutrition is the other thing to always keep in mind whenever you're thinking about secondary immunodeficiencies or people showing up with recurrent infections. And that's really and truly what we're talking about here. Think about all the different cofactors that go into have a functioning and healthy immune system. And somebody that is malnourished typically is lacking in some of those cofactors. So just keep in mind secondary immunodeficiencies as a causative reason for people who have recurring problems. If you can treat those secondary problem or the primary problem initially, hopefully your immunodeficiency will improve as well. So just keep those things in mind. All right, so how to suspect somebody with a primary immunodeficiency, or when should you really start thinking about those kind of things? So many years ago, the Jeff Modell Foundation, which is a foundation based out of Washington, D.C., came together to try to create or think through when we should be thinking about immunodeficiencies in children. Now, these haven't been updated in a little bit of time, but they still hold true, and they still are some guiding principles for when to think about patients with primary immunodeficiency. And so the criteria that the Modell Foundation uses for suspecting a primary immunodeficiency are the following. So yeah, the thing you have to realize about these is that they are not hard and fast. They're really meant to be guidelines for primary care doctors in terms of thinking through immunodeficiency. So greater than 8 infections in 1 year. So really and truly, if somebody has 8 true discrete infections in 1 year, you really should be thinking about those patients. Certainly as patients, enter into school or enter into daycare, they can have more than 8 infections in a year, and some of those blend into each other. So the 8 infections in 1 year really has to be somebody that is having discrete infections, but also taking into consideration what the circumstances of their lives are socially. Greater than 2 episodes of documented sinusitis or pneumonia in 1 year should raise the red flag for a potential primary immunodeficiency. And those are textbook sinusitis and pneumonias. Those are not the people who are showing up to urgent cares or different places and somebody's throwing a Z-Pack at them saying, oh yeah, you have pneumonia, or oh yeah, you have sinusitis. They meet the AAP guideline definition for either sinusitis or radiographic pneumonia. If somebody has a pneumonia in a recurring area, you may want to think about an anatomic defect, which would not be a primary immunodeficiency. So really have to take into account what that pneumonia looks like on the radiograph. Greater than 2 episodes of sepsis or meningitis in someone's lifetime should increase the risk or the thought process of having a primary immunodeficiency. You certainly would have some bad luck if you had 1 episode of sepsis or meningitis, and to have more than 2 episodes of either of those should really prompt somebody to thinking a little bit more about, okay, well, is this a immunodeficiency that's causing this? A family history of immunodeficiency increases the likelihood of somebody having a primary immunodeficiency. We'll see as we go through this list of different things, the different ways that these deficiencies are inherited, which may help you. A history of recurrent candidiasis or abscesses, and certainly solid organ abscess is really what we're talking about here, not skin soft tissue. Somebody with recurrent skin soft tissue abscess in today's day and age doesn't necessarily get people alerted as much as somebody who has, for instance, a recurrent liver abscess or a lung abscess or certainly a brain abscess. Those kind of things might make somebody more worried about having a primary immunodeficiency. The type of infections that you have may alert you to somebody having a primary immunodeficiency, excuse me. So if somebody has an opportunistic infections, a bacterium that is not a typical bacteria to grow in a specific location, if we have somebody with B. cepacia, obviously that's something we worry about in our cystic fibrosis patients. But if somebody has an opportunistic infection or a strange organism growing, it may alert us to having a primary immunodeficiency. Failure to thrive without organic cause is going to be on the list of just about anything, but certainly on the list of things that go with immunodeficiency. Specifically, if you have failure to thrive with recurrent infections, you may think about somebody having a primary immunodeficiency. And then the last thing is, if somebody has greater than 2 months of antibiotic treatment with little to no response. So if you know the bug, you know the drug that should work and the sensitivities that should work for that bug, and yet they're not clearing that infection, you certainly would want to take pause and think a little bit about, okay, is this because my immune system is not functioning properly? That may not be a numbers problem, it may be an actual functional problem with the immune system. And that may be part of what is driving the difficulty with clearing the infection. All right, so we have somebody that we think may have an immunodeficiency. So how do we go about getting screening labs, or what are some screening labs to really consider getting in them to kind of bolster our case? So the 3 labs that you'll really want to think about are usually a CBC with manual differentiation to look at the different cell lineages and types out there, quantitative immunoglobulins to see what are my immunoglobulin numbers, and then the gold standard or pre and post immunization titers 3 weeks following the vaccine. So knowing if somebody has a robust response to immunizations or adequate response to immunizations is still held as the gold standard, although you guys can know that that's typically not done clinically, just because of the time course that would take. If you have to give somebody draw titers, give someone an immunization, wait 3 weeks and draw post titers, that's a significant amount of time where you're kind of sitting there waiting. There are other tests that can be done more specifically that aren't considered screening labs, things like flow cytometry, and we'll get into some of the other testing that can be done. But really and truly, the thing that we want to be thinking about is thinking about the pre and post immunization titers. And let us know, it does not matter if it's live versus inactivated vaccine. Typically what we're talking about are not going to be live vaccines. If you have a concern for immunodeficiency, you're not going to want to give somebody live vaccine because you don't know if they're able to actually respond to that. The things that we're talking about here are really going to be pneumococcal titers is a big one that we typically use for that. So usually not live vaccinations. All right, so 5 different types of immunodeficiency that we want to be thinking about when it comes to our categories of them are humoral or B cell type immunodeficiencies are combined type, B and T cell, phagocytic or neutrophil type immunodeficiency, cell-mediated T cell type, and complement related. So the next graph that you guys are going to see kind of breaks it down a little bit in terms of what's the most likely to least likely. So if you get stuck on a test and do not know the way to kind of guess, I guess, what type of immunodeficiency, this next graph may help you with a little bit of that. So as you can see from this chart, almost 50% of primary immunodeficiencies are represented by B cell type immunodeficiencies. And only 2% are represented by complement related immunodeficiencies. So on a test, more than likely, if somebody has a complement related immunodeficiency, there's going to be something else in the stem of that question to point you in that direction. And we'll talk about what some of those things are here in just a little bit. But hopefully this graph kind of helps to show you how common some of these things are within the realm of primary immunodeficiencies. So B cell by far and away the most common, combined type the next most common, neutrophil predominant the third most common, then T cell only, and finally complement related. All right, so we'll go through each one of these, give you guys some general principles when it comes to immunodeficiencies, and then some specific disorders that are related to it. It's not going to be all encompassing once again. So humoral immunodeficiencies, what you want to think about is age of onset. So typically since 6 months of age or later, they usually present with recurrent sinopulmonary infections with typical respiratory pathogens. So we're talking about our MCATs, our pneumococcal disease, the typical bacterium that we see. There is an increased risk of lymphoma in patients with B cell type immunodeficiencies, which would stand to make sense. But the thing that we obviously, again, want to remember is that the age of onset is typically about 6 months of age or later, and that has to do with the waning of the maternal antibodies that happens. Now, the patient population you do have to be a little bit careful with that on are those born at the extremes of prematurity. If everybody thinks back to immunology during medical school, that lovely graph that shows when maternal antibodies peak, as well as the yolk sac begins to create its own antibodies, and then there's the internal drive of antibodies produced by the patient, and certainly has different times of waning. The general time period where a lot of the maternal antibodies are transferred are during the 3rd trimester. And so those born at the extremes of prematurity may actually have an earlier onset of humoral immunodeficiencies than the general population. Now, that being said, premature babies, we all know, have their own set of issues with infections and likelihood of infections anyway. So it can be a little bit of a problem in terms of differentiating that out. Here are the organisms, like I said, typical respiratory pathogens, so strep pneumo, H. influenza, MCAT, and enterovirus, typically are the organisms that we'll see. In particular, there's one disease process where recurrent enteroviral infections and enteroviral meningitis may kind of be a tip-off to an underlying primary immunodeficiency. So if you have a suspicion for a humoral immunodeficiency, definitive diagnosis is typically done by antibody titers and immunoglobulin levels. And that's the way you're going to go about trying to figure out if they have a humoral immunodeficiency. Different types that we'll talk about are IgA deficiency, X-linked or Bruton's agammaglobulinemia, common variable immunodeficiency, and transient hypogammaglobulinemia of infancy. So when it comes to IgA deficiency, is by far and away the most common primary immunodeficiency out there. It is a spectrum of disease with those people that have IgA deficiency, sometimes walking around completely asymptomatic and unbeknownst to them, to those that are fairly significantly affected. So there is a genetic influence of it. The majority of those with IgA deficiency have it inherited in an autosomal recessive fashion. There are autosomal dominant forms of it as well. However, the one that you guys will want to remember is the autosomal recessive form of it. Drugs can induce a relative IgA deficiency, so valproic acid, dilantin, and various sulfa drugs can induce a relative IgA deficiency that actually can be improved with this continuation of the medication. So just again, that's more trivia than anything else. You guys won't be asked that, but do know that drugs can induce a relative IgA deficiency. So when it comes to the clinical manifestations of IgA deficiency, the majority of them are asymptomatic. But if you think about where IgA lives, it typically lives in the secretory molecules or secretory system of our bodies. So thinking about the GI tract, thinking about sinopulmonary disease. It can present with kind of a milk allergy type presentation with recurrent diarrhea or intolerance of various foods. And the other thing to remember about IgA deficiency is that you can have an anaphylactic transfusion reaction if given IVIG, right? So just remember, IVIG is pooled immunoglobulins, including IgA. And if you give somebody with IgA deficiency IVIG, you can actually create an anaphylactic transfusion reaction. We used to screen people for IgA deficiency prior to administration of IVIG. But what you will see in terms of the treatment of IgA deficiency for severe cases is actually IVIG. And so because of that, you manage the transfusion reaction more so than anything else is the main thing that you would do. Obviously, you have to weigh the risks and benefits of the reaction compared to the ongoing infections that are going on. IgA deficiency for more moderate cases will at times have antibiotic prophylaxis given depending on the recurrent type of infections that they're having, particularly sinopulmonary infections. But this really should be managed under the kind of guidance of an immunologist. All right, so the poster child for humoral type immunodeficiencies are Bruton's agammaglobulinemia or X-linked agammaglobulinemia. It's a defect in the tyrosine kinase signal transduction molecule, and 85% of those are congenital or X-linked. Just again, as a piece of trivia, there is an autosomal recessive form. It is very, very rare to have. Stallworth will want you to remember that it's an X-linked disorder, but no, there is an autosomal recessive form of Bruton's agammaglobulinemia out there. So the clinical manifestations of Bruton's are, again, recurrent sinopulmonary infections with typical respiratory pathogens. Bruton's agammaglobulinemia, one of the unique features of it is that if you have somebody who has known intraviral meningoencephalitis, chronic form of that, they are at increased risk for Bruton's agammaglobulinemia. We've actually diagnosed a patient with Bruton's in the past due to this. He came in with 3 episodes of intraviral meningoencephalitis in a year's time period and was actually found to have the Bruton's agammaglobulinemia. So it was actually a pretty impressive thing. They have a higher incidence of other autoimmune diseases, including JIA and aseptic polyarthritis and dermatomyositis, and a important part of the clinical manifestation is that because of how early on in the signal transduction pathway this happens, people with Bruton's agammaglobulinemia tend to have absent tonsils and lymphoid tissue. They can't develop lymphoid tissue as well as some of their other counterparts will. So for diagnosis of Bruton's, typically, again, you're going to get your immunoglobulin levels. Serum immunoglobulin levels are extremely low or absent. They can have a relative neutropenia in a small percentage of the patient, and true diagnosis is usually done by flow cytometry. You can do a Western blot of the Bruton's tyrosine kinase protein, but that typically is more of a laboratory type diagnosis than anything else. Before the advent of flow cytometry, the Western blot was what we used for confirmatory diagnosis. So treatment-wise, what do they get? They get what they don't have, and that is recurrent IVIG. They will be coming in for monthly infusions, typically of IVIG, to help stem off any infections. And then aggressive management of co-infections. These are the patients where you're probably going to end up with recurrent IV antibiotics for infections and aggressive early intervention with antibiotics to help treat infections that may be occurring. CVID, we won't spend a ton of time on. As the name says, it is a very common disease process. It is probably, I'm guessing, immunologists corollary to chest pain in the cardiac patient, where people are showing up with concerns of CVID, and sometimes it doesn't really bear out. So because of the variable nature of it, it's known to be an immune dysregulation, but the true pathogenesis is not completely worked out. It may be accelerated B-cell apoptosis as well, but at its root, it has a wide variation in terms of what its presentation is. It's typically fairly rare in young children. It can present in kind of the school age child and into adolescence, but we really think about CVID more in somebody who's presenting with recurring infections in their 20s and 30s. As you guys can see there are a wide variety of different manifestations, increased risk of gastric carcinoma and lymphoma, as well as association with other autoimmune diseases. So what I would tell you is that anybody who's presenting as a teenager with autoimmune disease, in addition to recurrent infections, you might want to think about CVID, particularly if their autoimmune disease is otherwise well controlled. Now, that being said, like we said, medications, particularly things like steroids, can induce a relative immunodeficiency, so you have to take that into account as you're thinking about these patients. So for diagnosis of CVID, the buzzword that you'll want to remember is the absent isohemagglutinin. Patients with common variable disease will typically have absent isohemagglutinin. And the other thing to know is that in young children, you can't technically make the diagnosis of CVID in somebody less than 2 years of age because of its inability to be distinguished from transient hypogammaglobulinemia of infancy, which we'll talk about here in just a second. And that's something you guys will want to know about for our patient population. So treatment-wise for CVID, typically, again, it kind of varies from patient to patient for more severely affected patients. Again, it's going to be antibiotics for acute infections and IVIG on a monthly basis. You guys will sense a theme here when it comes to treatment strategies for a lot of these disorders. So transient hypogammaglobulinemia typically occurs, again, in those from 3 months to 4 years of age. It's more common in those less than 2 years of age. The majority of people with transient hypogammaglobulinemia of infancy are going to be asymptomatic. Typically, the way that this is discovered is that somebody has something that's a fairly common presentation. So, for instance, recurrent ear infections, a primary care doctor gets concerned that they have an primary immunodeficiency. They check immunoglobulin levels, and the number of IgG or different immunoglobulins is a little bit lower than what would be considered normal. So kind of at that low normal or just less than normal spectrum of things. Similarly, they have lower than expected vaccine titers. So if somebody were to get titer levels, they wouldn't respond as robustly as what you would want. They do have a response, but not typically as strong of a response. The nice thing is that these children, if they're followed out, will outgrow their disease. If they do not, they then go on to progress to CVID. So it's a little bit of a waiting game for a lot of these patients. For those that have recurrent severe infections, they may need IVIG infusions to help kind of get them over the hump, so to speak, of for the time where they're having their issues. All right, we'll move on to combined type, or the second most common type of immunodeficiencies that are out there. So the way that I think about patients with combined type, and I've actually lumped them together with T-cell disorder because the presentation is very similar, is to think about the patient that has end-stage AIDS. And because I think that is really the hallmark for somebody with combined type or T-cell mediated immunodeficiencies. Typically, the age that these patients present are very, very young for combined type or T-cell type. They can present with recurrent pneumonias, particularly with abnormal organisms, or recurrent thrush, or candidiasis, candidiasis in strange places, candidiasis that doesn't quite fit the picture. Candidiasis in a patient that's school age obviously is something that would be concerning for you. Somebody who has poor growth and failure to thrive with immunodeficiency surely should be something that you think about with combined type or T-cell mediated. And then somebody with persistent diarrhea that tends to be more of a secretory diarrhea is somebody that you would think about as potentially having T-cell mediated or combined type immunodeficiencies. So the type of organisms that you'll see are basically all of the organisms. So any type of the B cell type of organisms that we talked about, the typical respiratory pathogens, the strep pneumos, the MCATs, the H influenzas, are fungal infections, recurrent viral infections, or any opportunistic infections. So really and truly, we're thinking about just about any type of recurring infection. Some examples we'll talk about are DeGeorge syndrome, SCID, or severe combined immunodeficiency, hyper-IgM syndrome, ataxia telangiectasia, and Wiskott-Aldrich. So everybody think back to embryology real fast. Okay. now that you've had that horrible flashback, just remember that DeGeorge syndrome is really and truly a problem with a dysfunction in migration of the third and fourth pharyngeal pouches, which results in thymic absence or hypoplasia. And that's what drives the immunodeficiency surrounding DeGeorge syndrome. There are different kind of variations of DeGeorge syndrome. So Spritzen syndrome, velocardiofacial syndrome, and DeGeorge syndrome are all kind of in the same kind of area as DeGeorge, but the actual syndrome as described by DeGeorge has some specific characteristics, which is usually known by the catch-22 that we kind of use. So catch-22, for those of you who can't or don't remember the mnemonic of it, is cardiac abnormalities, abnormal facies, thymic dysplasia, cleft palate, hypocalcemia, and a defect on chromosome 22q11.2. So you'll want to remember that to go along with the associations of DeGeorge syndrome. The next slide is a little bit controversial, but if you're going to be by the book, it's completely trivia. I would tell you guys not to remember this at all, but in order to have the true diagnosis of DeGeorge syndrome, the immunodeficiency is a key hallmark of that. We always think about the cardiac defect, but it's actually one of the additional kind of markers of DeGeorge syndrome. So to have true DeGeorge syndrome, you have to have primary immunodeficiency along with the conal truncal defect, the hypocalcemia, or the confirmation of the 22q11.2 by Fish. Just again, that's trivia. I would not necessarily memorize that or remember that. But now that I've said that, that's the only thing you'll remember from this lecture, I'm sure. Treatment-wise, there are a lot of different things out there. So IVIG is still the mainstay of treatment for these patients. Antibiotic prophylaxis is something that's used. You can actually do a thymic transplant for these patients. The issue that happens with that, though, is that you actually end up inducing a secondary immunodeficiency potentially because of the need for solid organ transplant. So those patients will oftentimes require ongoing immunosuppressants, to prevent things like graft versus host disease. So by improving the primary immunodeficiency, sometimes you can create a secondary immunodeficiency, and that's why it's not the mainstay of treatment currently. It is used for patients that are having problems with recurrent infections despite IVIG infusions and aggressive management of their infections, but just know that it's not the primary mode of treatment just because of the secondary immunodeficiency it can create. So severe combined immunodeficiency, or SCID, has a lot of different types of disorders, but know that it happens very early on in stem cell development, and that's why it is such a catastrophic disease process, and why it's now something that we screen for on our newborn screens. It affects both B and T cells and various forms of inheritance, and we'll talk a little bit about these various forms, but you guys just need to know that it is a combined B and T cell type disorder that affects kids very early on. So the pathogenesis of it really depends on the genetic defect and resulting lymphocyte phenotype, whether it affects the T cells, the B cells, or the natural killer cells. But the commonality of all of it is that it affects functioning T lymphocytes. That's one thing that is common to all forms of severe combined immunodeficiency. The most common type is X-linked type. About 50% of the severe combined immunodeficiencies that are out there are X-linked. It results in a total failure of B and T cells. And with that being the case, it certainly affects patients very, very early on. And because of that, genetic analysis is super helpful and something that would want to be known because it can affect future pregnancies. And so typically, if a patient is diagnosed with X-linked severe combined immunodeficiencies, the mother should be screened to see if she's a carrier for future pregnancies. ADA type SCID or adenosine deaminase type SCID is far less common, but it does have a genetic treatment, a enzyme treatment that can be helpful. So we actually give patients with ADA type SCID PEG-ADA, which is polyethylene glycol type ADA. So we give them gene replacement, and they can have return of function of some of their T lymphocytes, which is one of the few helpful or I guess landmark cases of genetic therapy, gene therapy, which has been great for patients with severe combined combined immunodeficiency. It's inherited in an autosomal recessive type form. And again, these patients are sick within the first few months of life. Rag type SCID is the most common or most severe form of it. It has normal natural killer cells, but no functioning B or T lymphocytes. Bone marrow transplant can be used in these patients to variable success. So the clinical manifestations of patients with severe combined immunodeficiency, again, include severe recurrent infections, chronic diarrhea, failure to thrive, opportunistic infections, and then aberrant lymphoid tissue, as you guys can see there. For diagnosis of SCID, typically flow cytometry is something that will be used for them, as well as genetic analysis. Again, we have a newborn screen at this point in time that tests for the more severe forms of severe combined immunodeficiency so that we can intervene earlier on. But for true diagnosis, they have to have less than 20% of functioning lymphocytes or T lymphocytes. Their absolute lymphocyte count is usually less than 3,000. Back in the day, the way that we used to actually evaluate these patients was for what we would call mitogen testing, which you can think of as almost a modified PPD, where we injected candidal antigens to see if there was a response to the candidal antigen intradermally for these patients. If there was no response, that typically would indicate to us that we didn't have functioning T cells to help with the intradermal injection of the candidal antigen. We don't really do that anymore, but again, more of a historical point than anything else. So treatment-wise, really depends on the type of severe combined immunodeficiency that somebody has. A lot of them will go on to bone marrow transplant, and even after that, some will still need IVIG to provide B-cell improvement. We talked about PEG-ADA, and the thing to remember from Dr. Hahn's lecture, the immunization lecture, is that patients with severe immunodeficiency, severe combined immunodeficiency cannot get live vaccinations. We'll talk just real briefly about hyper-IgM syndrome. We have a few patients, or at least one I know of, that has hyper-IgM syndrome. So this is an inability of class switching at the immunologic level. So if you guys remember, in order to cause immunoglobulins to switch from IgM to other types of immunoglobulins, a B and a functioning B cell and a T cell have to come together in what I like to call the lock and the key in order for cell signaling to happen to then result in class switching at the immunoglobulin level. That'll be shown kind of in the next picture here. So the two deficiencies can be either in CD40 or CD40 ligand, which are kind of those lock and keys. So here, you guys will see the B cell and the activated CD4 cell. So CD40 and CD40 ligand come together after the antigen has matched to the surface immunoglobulin through the mechanisms of the different biomarkers that you guys can see here. That then results in class switching from IgM to other types of immunoglobulins. So what happens is, if you can't create this key and lock, which then induces the signaling to happen, you get an abundance of IgM with very minimal changes to IgG, IgA, IgD, IgE type of immunoglobulins. There are other mechanisms to get this class switching to happen, but by far and away the most robust is to have the CD40 and CD40 ligand come together. So what they have, again, recurrent cytopulmonary infections with encapsulated bacteria. These patients will have lymphoid hyperplasia, which is in contrast to our Bruton's A gamma globulinemia, which had hypoplasia, because these patients are trying to kick out the IgG. They're not getting that negative feedback to say, hey, we've got enough. So they typically will have lymphoid hyperplasia. And again, they have increased incidence of autoimmune pathologies, diabetes, hepatitis, rheumatoid arthritis, IBD, uveitis. For those of you who know our patient with hyper-IgM syndrome, you know he has a lot of other autoimmune disorders as well. So diagnosis, again, hyper-IgM would tell you it has elevated levels of IgM with low levels of other immunoglobulins. So treatment, typically chronic IVIG, anti-inflammatories, immunosuppressants to prevent the development of other autoimmune pathologies can be very helpful, and then aggressive antibiotics for active infections. Telangiectasia is a DNA repair defect that occurs. It's inherited in an autosomal recessive form. These patients have a problem when they have cross-linking of thymine dimers and can't excise those thymine dimers and replace them appropriately. So the DNA is not appropriately repaired when that sort of thing happens. So these patients are very, very exquisitely sensitive to ionizing radiation, and something you'll want to take into account if you know somebody has ataxia telangiectasia to make sure we're giving them the lowest amount of ionizing radiation possible. So the way that they typically present are ataxia due to degeneration of the Purkinje cells. Usually by 5 years of age, they'll have recurrent telangiectasias, typically in sun-exposed areas, the eyes, the skin, the face, the forearms, those kind of areas. Usually happens early on. In order to have the diagnosis, you have to have 2 of the 3 of ataxia telangiectasia and increased alpha fetoprotein, and they'll present with bronchiectasis, which is one of the few presentations that we'll see bronchiectasis in children, the others being kind of cystic fibrosis and other intrinsic lung diseases, but it's the one immunodeficiency where you'll see bronchiectasis. So Wiskott-Aldrich, those of you on HEMONC or that have been through HEMONC have probably talked about Wiskott-Aldrich at some point in time. It goes along with a triad of thrombocytopenia, eczema, and immunodeficiency. It's inherited in an X-linked form. And the pathogenesis of it is a defect in the WASP gene, resulting in both T and B cell dysfunction. Typically, these patients will have small and few platelets, will have post-circumcision bleeding, and may present with bloody diarrhea. And then the eczema is typically an IgE-mediated as well as eosinophilic eczema that you'll see. Treatment for patients with Wiskott-Aldrich, IVIG, again, mainstay of treatment for many things for primary immunodeficiencies are things like IVIG, bone marrow transplant, antibiotic prophylaxis. But the caveat to Wiskott-Aldrich is you can actually do splenectomy for these patients, which actually can increase platelet count. So you really want to think about that in patients that are having recurrent bleeding issues or problems with severe thrombocytopenia. However, by doing that early on, you may increase their risk of immunodeficiency by inducing a secondary immunodeficiency through creating a true asplenia and increasing the risk of their having infections with encapsulated bacterial infections. All right, we're going to try to move through these last couple here pretty quick. So phagocytic immunodeficiencies really can be a problem with either production or function of the neutrophils. Can happen at any age, but usually infancy is the time period where we're starting to see this. The type of abscesses we're really going to want to think about for phagocytic immunodeficiencies are going to be those with skin or solid organ abscesses, recurrent pneumonias, dental infections, those type of things. The organisms that can cause problems are typically catalase positive organisms, things like staph and serratia, and not catalase negative organisms like streptococcus. Gram-negative organisms like E. coli, Klebsiella, and Proteus can give you issues with your different types of phagocytic infections. And then Aspergillus and specifically aspergillomas are things you want to think about in patients with neutrophil type disorders. All right, so the 4 that we'll talk about are LAD type 1 and type 2, Shiraki-Higashi syndrome, chronic granulomatous disease, and hyper-IgE syndrome. So LAD type 2 is kind of the one that everybody knows from pediatrics that you guys learned about during your 3rd year that results in problems with the leukoid site. Extravasating out to where it needs to be. And so I think this picture, this graphic, hopefully helps you guys to see kind of what the problem is. So with LAD type 1 and type 2, the problem is a beta-2 integrin molecule and CD18, so it's a protein defect. Normally the phagocyte will bind to the endothelium of the blood vessel, will kind of roll along it. It will get the signaling that, hey, there's an infection going on. I need you to get out of the blood vessel and get to where you need to be. It'll extravasate itself out of the vessel and kind of infiltrate into the area. With LAD type 1, what can happen is it will bind to the endothelium, it will roll along the site, but it doesn't have that beta-2 integrin to actually extravasate out of the blood vessel. So what happens is you have a bunch of different white blood cells sitting in the blood vessel that can't get to where they need to get to. This is in contrast to LAD type 2, which has a problem with a fucosylated ligand, and it cannot bind to the endothelium. If it could bind here, it could extravasate out and get to where it needs to get to. It just has a problem with binding to the actual blood vessel endothelium. Okay, it's inherited in an autosomal recessive type pattern, and so it kind of makes sense if you understand the pathophysiology of the disease, kind of what happens. So clinical manifestations, the big one is the delayed separation of the umbilical cord. You'll form what are called cold abscesses. Oftentimes you'll have some abscesses that are not warm to touch. They may have a paucity of polynuclear cells present in them when you sample them and do their grand stain. Very, very elevated levels of white blood cells when you go to check them, because again, they're all in the vessel. So when you stick the person to get the CBC, they're all sitting there waiting for you. And the way that it's truly diagnosed at this point in time is via flow cytometry. Treatment for it, bone marrow transplant for severe and moderate forms, and antibiotic prophylaxis and aggressive antibiotics for acute infections. These are not the ones we're going to want to use bacteriostatic antibiotics. We want to use bactericidal antibiotics whenever possible to treat their infections. Again, we talked about LAD type 2. The nice thing about LAD type 2 is that there is actually a gene therapy available for it. You can give them a fucosylated ligand to treat the E-selectin problem and can have regain of function of the neutrophil. The issue with it is that there's a severe phenotype that is typically associated with it of abnormal facies and severe intellectual disability, small stature, that by the time that it's recognized, oftentimes is not going to be improved via giving them the fucosylated ligand. All right. Shediac-Higashi syndrome is a syndrome that causes problems with the superoxide anion burst or respiratory burst that happens with neutrophils. So typically your neutrophil function or numbers will be normal, but the functionality of the neutrophils aren't working. The gene defect is in the LIST gene, and it is inherited in an autosomal recessive type pattern. The manifestations of it, the way I think about it, is pain. So pyogenic infections, which tells you the immunodeficiency associated with it, partial oculocutaneous albinism, neurologic disturbances like photophobia and seizures, and elevated eosinophilia are the four things that are associated with Shediac-Higashi syndrome. The diagnosis shows abnormal giant lysosomes. Again, they don't have the negative feedback. They are trying to create this respiratory burst and having a buildup of abnormal proteins and resulting enzymes from it. Neutrophil numbers are usually mildly decreased to normal, and you can also have a problem with natural killer cells. So this is one of those giant lysosomes that you would see typically in Shediac-Higashi syndrome. Steroids can actually be helpful. It can actually improve the functionality of the LIST gene if there's only if there's not a total deficiency, excuse me. And bone marrow transplant can also be helpful for these patients and actually be curative for a lot of patients with Shediac-Higashi syndrome. CGD, or chronic granulomatous disease, you'll want to know about. Again, problem with creating the respiratory burst, the bactericidal H2O2. Typically at a very young age is when it's diagnosed. Recurrent mouth ulcers, osteomyelitis, lymphadenopathy is the way to think about it. The way that we typically think about chronic granulomatous disease is it being an X-linked recessive disorder. There is, again, an autosomal recessive disorder associated with CGD, but for purposes of your test, you're going to want to remember that it's X-linked recessive. The way to diagnose it typically now is flow cytometry is the way to actually diagnose it. The way that you'll hear about or see on antiquated tests is the nitro blue test. So failure to reduce nitro blue would typically tell you that somebody had CGD, but at this point in time, flow cytometry is actually used to differentiate it, because it can actually differentiate X-linked recessive and autosomal recessive states of CGD, as well as carrier states. So flow cytometry is typically the actual diagnostic test at this point in time, and you guys can see some of the treatments available. Interferons can actually be very helpful in patients with CGD. All right, coming to the end here. So hyper IgE syndrome or Job syndrome is a problem of neutrophil chemotactic factors. That's why it's actually kind of placed in the realm of phagocytic disorders, because that's the true immunodeficiency that it has, is a problem with cell signaling for T cells and for neutrophils predominantly. It's the one that we're going to talk about that's autosomal dominant in nature. And so that's something for you guys to remember. Obviously, clinical manifestations, if it has Job syndrome, for those of you familiar with the story, are recurrent sinopulmonary and skin abscesses, a very pruritic dermatitis, usually during the first weeks of life that can be confused with eczema. Just remember, for atopic dermatitis or eczema, patients typically will need a recurrent kind of exposure to something before they demonstrate the manifestations of it. They have to kind of generate that allergic response, whereas this is more of an intrinsic hyper IgE issue being produced. It's not based on exposure. So if you have somebody with a very, very pruritic dermatitis early on in life, really consider Job syndrome or hyper IgE syndrome. Again, peripheral eosinophilia is going to be marked there, and elevated serum IgE levels, and then on flow cytometry, neutrophil chemotactic defects where the neutrophils aren't migrating as they should. All right, last part of things, complement-mediated immunodeficiencies. So again, this is by far and away the least common of all immunodeficiencies. It only accounts for about 2% of all immunodeficiencies within the primary immunodeficiency realm. Can happen at any age, but usually infancy is when we start to see these things. School age is when they really come to bear, and they become very, very evident. The presentation is typically in association with other autoimmune syndromes, and we'll talk about how to differentiate the different types of complement-mediated immunodeficiencies based on the autoimmune syndromes they're associated with. These result in pyogenic infections. These are typically not viral infections that we're going to be worried about, and there's an increased association with glomerulonephritis. So that's why you'll see Dr. Kramer and Dr. Holloman anytime they're working somebody up for recurrent or significant glomerulonephritis, wanting to get complements to see if they have an underlying immunodeficiency that may be associated with it. Okay, so the types of organisms that you're going to see are all of your encapsulated organisms, your B-cell organisms, plus Neisseria meningitis. So Neisseria typically tends to be the most significant and common one that we see showing up in patients with complement-mediated immunodeficiency. The vast majority of them are inherited in an autosomal recessive pattern, and certainly something that you'll want to keep in mind how they're related. So the two major groups that you'll see are early manifestations and terminal components. So the early types of complement-mediated immunodeficiency are your C1 to C4, if you remember the complement cascade, which I'm sure all of you do. And then the terminal components of C5 through 9 are the membrane attack complex that's associated with it. So again, recurrent sinopulmonary infections, typically encapsulated organisms causing you issues for your early complement-mediated immunodeficiencies. The textbook way of knowing if somebody has a complement-mediated immunodeficiencies is to get what is called a CH50 and an AH50, which assess the common pathway and the alternative pathway of the complement cascade. So for those with a early complement-mediated immunodeficiency, what they will have is a normal AH50, so they can actually go through the alternative pathway for creating complement, but their CH50 will be low. That's in contrast to the terminal component, which will have a low CH50 as well as a low AH50. Okay, some of the more common ones, and then after you've kind of gotten into that early versus late complement kind of area of things, then you can screen for, okay, these are the more common areas for complement-mediated immunodeficiencies, whether that's C1 to C4 or C5 through C9. C2 deficiency is the most common primary immunodeficiency related to complement. That does not mean that it is the most common complement deficiency. C3 and C4 are by far more common, but because of their association with other autoimmune diseases, that's the case. If it was just primary immunodeficiency, C2 is the most common of them. C3 deficiency has an association with post-strep glomerular nephritis, and C4 deficiency is associated with autoimmune diseases like lupus. The one that again, Holloman and Kramer are really concerned with is C3 deficiency if somebody has post-strep GN. C5 to C9, this is the membrane attack complex. This is where you're going to have problems with Neisseria species, meningococcal and gonococcal infections, as well as your encapsulated organisms. And like we talked about, these patients will have a decreased screen for both CH50 and AH50 in the textbook definition of complement-mediated immunodeficiencies. Treatment for patients with complement-mediated immunodeficiencies typically is aggressive antibiotic management. There are some genetic therapies available out there that haven't been really super successful in getting them treated. Obviously, you'll have some case reports of improvement, but for the most part, aggressive antibiotic treatment is the mainstay of treatment. Okay. All right. So that is all I know about immunodeficiencies. Apologize for Dr. Black not being here today. We'll try to figure out what happened and get you guys any materials that he has, but hopefully that gives you guys some idea of an overview of immunodeficiencies, kind of how to think through them a little bit, and at least give a framework for trying to get you guys into, is this a secondary versus a primary immunodeficiency? If it's a primary immunodeficiency, what are the kind of 5 categories of immunodeficiency I have? And then what are some specific categories within that, or the diagnoses within that may fit the mold based on clinical manifestations of this patient population, and some principles for diagnosis and treatment. So hopefully you guys all have a good day. Hopefully everybody had a good Labor Day. Again, apologize for Dr. Black not being here, and everybody have a good rest of your day. Thanks.